Yeah, I think I've been thinking about this a lot more lately. I imagine we're filming, but we can just talk. Is you started I was kind of like, tell us about yourself and how you got to where you are today. And you started off with how your childhood informed your life. And I don't know if we get those opportunities as much to talk about how our childhood and our upbringing informs the work that we do currently. And we kind of keep our professional lives and our personal lives so separate.
Yeah.
But I would agree with you in saying that my childhood growing up here and seeing immigrating here as a infant with my family, seeing my parents create a life for my brother and me through a lot of struggle, through my father working at night and my mom working in the day so they could pass their kids off. My mom taking English classes at the Winooski Public Library. All these different things that kind of create the way that they piece together a safe and beautiful life for my brother and I. Informs the work on what I went on to study at school and how the systems and the barriers that they were presented with, how those came to be, how we can use the power of government and policy to change those things. And then now into the work now, I'm in the racial equity space as well. And specifically my family and creating a better life for them because they still live here informs my work all the time. As well as creating a better upbringing for the youth that exists now than I had, given growing up in Vermont. So I guess I appreciate that you brought in that personal perspective because you don't hear that a lot from seasoned professionals. You don't hear that a lot from people doing kind of the big work. But I agree with you that it every day informs the work.
Yeah, it does. And whether it's psychology, mental health work, or it's advocacy or DEI, which DEI has become this buzzword, but so many people were in that space before. It's like been this like co-optive term that's like now like HR and corporate. But like, come on, people were doing that for centuries. I just lost my thought. But to be able to do it, like we are the tool. Like we have to throw ourselves into it. And so what I teach our residents is, one of the skills we're working on in our competency areas for their whole training year is using their self as a therapeutic tool. How do you have to be self-aware as your own self as a cultural being, but also what are your triggers? What are your, what's your worldview in order to be able to support other people in figuring that out?
Yeah, certainly.
And so I wish more people talked about that. I think, I do think that we have to really take a de-hierarchical approach. Like, let's just, if we're going to talk about systems, like we need to talk about like what are the structures in place that are perpetuating the oppression and how can we dismantle that? Can't do that without community.
Definitely. I guess, can we talk then more about the barriers for getting adequate care in Vermont, I guess, for BIPOC people of color in Vermont? What do you think are some of like the biggest barriers that come in a predominantly white state for care?
I mean, so there are a couple of things that come to mind. I mean, one we've touched on a little bit is just like lack of availability of practitioners. Like there's just not as many of us here that are providing the services that have open spots in our caseloads, things like that. And then I also think it's, there has been a lack of training around cultural humility. I think trauma-informed care needs to be like a set requirement for competency and for licensure, instead of something that you can opt in or opt out. Like you shouldn't be able to go through graduate school to be a therapist or a psychologist and not take specific courses on trauma, on racial trauma. But yet it isn't a requirement. So, I do think that there are many people that have tried and have sought care and have been harmed in the process. When people reach out to me, that is often the case. Like they have had a harmful interaction with a provider that wasn't culturally humble or culturally aware. And so I think then that can really deter people from continuing to try. I do think that there, in terms of our licensing jurisdictions, there are some barriers there. Now telehealth is, a pretty well accepted thing. Many people are used to doing therapy online. But the way that our licensing is, particularly for psychologists at the doctorate level, you can only practice even telehealth if you're licensed in the state that the patient lives in. So, for example, for me, I'm licensed in Georgia and Vermont, so I can see patients in both of those states. But imagine if if there were some changes in that structure, and there's some legislation actually that I can talk about in a moment that's looking at that. That would open up so many opportunities for people of color in Vermont to then work with, via telehealth, other providers of color that live in other states.
That would be huge.
It would be huge. And there are so many states that have signed on to what's called PSI-PACT, which is kind of an, what's the word I'm looking for? Interjurisdictional, I don't know, it's this long term, but essentially it allows providers in certain states where this legislation has been passed to practice outside of the state.
Okay.
And so Georgia is a part of it. A lot of other states are a part of it, but Vermont is not yet. And so that's something that every opportunity I have, I talk about. It's called PSI-PACT, because you can read about it online. Because the more advocacy we have for that, that would help a lot with the mental health prevention, the therapy access. So those are some of the main things. And then just in terms of psychiatric care, we just don't have enough beds in this state. There are not enough psychiatric beds. And so then the emergency departments get backed up and the patients don't really get the therapeutic care that they need.
So you talked about having a culturally aware kind of practitioner. How would you recommend people assess that? What is the best way to ask questions, or how should one looking for a culturally aware practitioner who can meet their needs? How can you find one and assess that?
Yeah. So when a lot of people reach out, family and friends, and then just, patients that I don't know in the community asking about that. And I like to say, it's kind of like looking for your favorite pair of jeans. You may have to try on a couple. And what I mean by that is you can start online. You can go to psychologytoday.com, put in your zip code or your insurance. You can even filter the search results based on racial identity of the practitioner. And read some bios, look on some websites, and then I would reach out to at least 2 to 3 and ask for a phone consultation. The majority of people provide complimentary phone consultations, usually 15 minutes, and you can see and check in with yourself. How do you feel talking to this person? Do you feel comfortable? Do you feel like they have a curiosity about you? Do you feel like, they're kind of just going through their spiel and like on to the next? Like, do you feel hurried? Like really notice what it feels like talking, and then schedule an appointment with a couple of people and do that first initial appointment and then really see what it felt like. Because again, if there's going to be any success in the therapeutic work, like you have to have that relationship there. For patients that contact me through my private practice, I always say the first 3 sessions are getting to know you. You need to know how you feel working with me. I need to know how I feel working with you, and if I feel that like my background and skills are what you need. And so, then after the 3rd session, we kind of talk about if it's a good fit, or I provide referrals. And so, I would encourage folks to feel empowered to do that for themselves. Don't keep going to somebody if you're not feeling comfortable because you feel like you have to. Don't do that to yourself, But asking and doing that phone consultation and then scheduling some initial appointments, and again, really being in tune with how you feel talking to that person. I think some questions that could be asked during the phone consultation are, does the provider have experience working with people from whatever your specific identity that you're looking to get, that you want to, connect with a person around, whether it's your gender, or sexual orientation, race, language, religion. Do they have experience working with clients or patients from that same background? How do they, you could ask, what are some of the main presenting challenges or problems do they work with? Do they have a background in working with trauma or racial trauma? How do they view their role as an advocate? Is advocacy a part of their practice? Asking those kinds of questions. Because if you're looking to get some support around anything that has to do with your identity and you are meeting with somebody that doesn't have any experience, you will likely be in the role of teacher. And that doesn't feel so good.
Can I ask then, you kind of talked about trauma-informed care and racial trauma specifically.
Yeah.
Just more broadly, can you elaborate on how you see racial trauma show up? I guess I would hope anyone watching this to understand, if they're not well aware of what racial trauma is and how it shows up in the big and the little ways. Can you talk about that a little bit?
Yeah, I'd be happy to. And before I kind of dive into my understanding about it, I'll just offer a resource. So Dr. Joy DeGruy, she coined the term and also describes the theory post-traumatic slave syndrome. And she describes it beautifully about how it can show up in big and little ways. But essentially, when we think about post-traumatic stress disorder, it is a mental health disorder that was really kind of founded on seeing what was happening with the Vietnam veterans that were coming back to this country and the trauma that they were experiencing. It's now been expanded to look at, many different communities. But having a historically marginalized and excluded racial identity in this country means something really significant in terms of, again, multi-generational trauma that's been passed on, but also there are entire systems that have historically been created to prevent our advancement and success and healing. And so, whether you're looking at, housing discrimination laws or even medical practices like the Tuskegee Institute, or experiment, right? And so needing to have the historical context is important for providers to be able to work within the racial trauma realm, but also understanding the impact of microaggressions. Those like subtle, can be indirect, daily slights and indignities that are discriminatory in nature. It can be as simple as one of my first interviews when I came to Vermont. It was, I won't even say where it was. It wasn't the medical center, I'll say that. At the end, you are so articulate, Dr. Coleman, from a white male. You are so articulate. There would be a lot of people that would want to see you in this practice. And I bet we'd get a lot more people of color if you were here because you communicate so well. And of course, that was the interaction and conversations ended there. But that's an example of a microaggression. What did he expect I was going to sound like or how I was going to communicate, considering it was a job interview and he had my resume and CV? So what was the expectation about how I was going to present myself, right? And so there are people that can come in for therapy that experience those kinds of things every day. And that impacts their mental health, right? And so again, a provider that has the awareness and understanding of racial trauma, it's the big things about the historical discrimination and the multi-generational effects of trauma, through the Jim Crow era and then, the transatlantic slave trade, right? There's been so much trauma and there's been no collective kind of institutional push or even government push for healing. And then, don't even get me started on the indigenous genocide that happened, right? So of course there's trauma there, but then you go into everyday spaces and systems that are kind of ignorant to that. And then you have all these microaggressions. And so for many, it just becomes too much to bear. So if a practitioner doesn't know that, isn't aware of that, it would give me pause.
Then can you also first of all, thank you for walking us through all of that. I think it's important for anyone trying to understand this, to understand the history of it all and how we take that through our bodies, like you said, as well as the experience of if your ancestors were enslaved or if your ancestors were killed in a genocide, all of that. And then also people from other places, like my family, leaving a civil war, or other families that have to leave so much trauma behind and come here, and we're all mixing together and trying to live a happy life together. But everyone's bringing their own trauma. So you talk about trauma-informed care. I imagine there's a broader definition to that I'm not aware of. Can you give us kind of what trauma-informed care is?
Yeah. So the way that I would describe it to my clients or my patients is that it's care that takes into account and is informed by, aware of the wide array of trauma that everyday citizens experience. And so, the way meaning that it informs the policies, the practices, how we do intakes, the questions we ask, collaborating on the treatment plan, an awareness of the trauma that not only sits within the system and how systems can then trigger trauma, but how do we understand a patient's behavior? Are we stigmatizing it and saying, oh, they're non-compliant, it's an aggressive patient, they're not grateful for the work that they're being, that the resources provided to them? Or is it, oh, they must be triggered. I wonder if there's something in the system that's triggering them. Let me join with them and get some more, lead with cultural curiosity and understand what may be triggering. We see this a lot when prior to my current role, I used to lead the medical psychology consult service in the medical center. And so we would provide bedside psychotherapy to 13 med-surg floors in the hospital. And there was so much trauma. I mean, when we think about, anyone that comes into the hospital, particularly during the pandemic, there are power dynamics that can be really triggering for anybody that has a trauma background. Feeling as though they don't have autonomy, they can't come and go as they please usually, also incredibly vulnerable, and like their care is in the hands of strangers. They don't know their care team. And so if a provider is trauma informed, they would be aware of that. They would maybe name that with the patient. They would also recognize, we need to collaborate together because you know more about what you're experiencing and the pain and what it feels like in your body than I do. I need you to share that with me. Yeah. Right? Like that's an example of like a trauma-informed interaction.
Okay, I think another direction I want to take this so we have time. So we talked about practitioners of color and trying to, there are efforts across the state, even within VHEI, to try to increase that number. But until that number, is on par with the people of color in Vermont looking for care, I guess what would you say about the care providers that are already here, that are white, that are trying to commit themselves to be ready for that type of work? I guess what are your thoughts and recommendations there?
Yeah. There are the number of white providers that I work with in the psychological services department at the medical center that are committed and dedicated to this work and have been for years. And I often refer people of color to them. What I have seen my colleagues do is they really dive into their own learning. They step outside of their comfort zone. They've had to do their own kind of racial and ethnic cultural identity work, where they do cultural self-assessments. We talk about it in team meetings and our group consultation. And then, they lead DEI didactics with residents, right? They're recognizing that there is a responsibility that they have, not only for their own learning, but for the kind of care that they're providing patients. And I think there are a number of white providers that are doing that are diving into it, that recognize that this is an area of practice that they want to work in, that they want to specialize in, and that there's some due diligence that needs to be done. I do have a list of referrals of providers that are white that I trust to work well with patients of color. I think that for many of us, we have to do continuing education to renew our license every 2 years. And so, more continuing education offerings that speak to some of these themes, that helps to train providers in the area. So that's something that we've been trying to do with our Grand Rounds series at the medical center, but also one organization that I think does this really well is NFI. They do, and I'm going to blank on what that stands for. I just know NFI is a community organization that does a lot of really good mental health work. But they provide a lot of great continuing education for practitioners that want to work more with diverse communities, also like around racial healing.
Then if someone's looking for a practitioner, unfortunately, a lot of times that isn't covered by health insurance. I guess the question of why is, there's a whole host of questions, but how do you see the landscape of ensuring that mental health is part of we have our normal doctor's checkup. We have a dentist, 2 dentist appointments a year. How does that, it might be the other way around, but we have regular doctor's appointments. We have regular dentist appointments, and a lot of times those are covered by insurance. mental health isn't always covered by insurance, and there isn't really a regular mental health check-in that's infused into our kind of care throughout our lives.
Right.
What is that? What are your thoughts on that, I guess?
I mean, I think it's a big problem. It's certainly something that bothers me a lot. I mean, I'm sure it bothers many people, because you're right. Like, we, go to our physician or medical provider, dentist, eye doctors can even be covered. And it's like, okay, well, what about our mental health? So a couple of thoughts about that. I think that organizations have a responsibility to their employees to provide mental health insurance coverage. And so if there are employees that are at organizations where they are not receiving that benefit, advocate within your system, for that, because I do think that organizations should be providing that, particularly given how stressful working during the pandemic has been, the stress just that's been going on in our society. And we also, been going through the Great Resignation, where every single industry is impacted by not having enough people to employ. So prioritizing the employee wellness, I think, is actually a recruitment and a retention tool for organizations. Then there's policy advocacy. Being a practitioner in private practice that did not take insurance, I can say that for providers, it can be really hard because of the very low reimbursement rates. And so that's often the reason that many providers may not. I think what I did was I took pro bono cases and did sliding scale. And then when I was in Atlanta, I got on Medicaid panels. But even then, it is really hard for practitioners to to have their fees honored, but also to even receive reimbursement from insurance companies. The whole managed care piece is really complex, and there's a lot of kind of overhaul that I believe needs to be done. So there's advocacy on all of the systems levels, I think, is needed. But I will say, as a practitioner, many practitioners do not get on panels because of the rates of reimbursement. You see so many patients, and there's such a risk of burnout, and the financial return to make a living is not always feasible. But there are many people, I would say, in Vermont, opposed to some other larger cities. A lot of providers I found do accept insurance. I think this just needs to be a larger conversation about, but advocacy is at the heart of it.
Then can we close out with this concept of having a larger conversation? All the people need to be at the table having this conversation. Institutions, insurance companies, practitioners, clients, people in the community, employers, all these people that you've mentioned throughout this conversation. Can you paint a picture of why BIPOC mental health equity at large is important, benefits us as a community at large? Can you speak to that a little bit?
Yeah.
Why people should care.
Right. I'm gonna give a plug for the Health Equity Summit, because I think that we're part of the conversations. That's the Health Equity Summit that's going to be on October 20th at UVM, the Davis Center, because the keynote is Heather McGee, and her book, Some of Us, What Racism Costs Us All, speaks exactly to that question. It isn't just a Black and brown thing and not a white thing. It impacts every single one of us, because not only are our organizations more innovative and more fruitful, and revenue flows more when people feel like they have a sense of belonging and all diverse opinions and thoughts are valued. That's been researched to the hills, and it's true. And it matters because we are here. We are a part of the society. It should be our birthright. I think it is our birthright, although the country hasn't fully always acknowledged that. And because, we have so much to contribute. So I think there are so many ways to look at it. It matters from a system standpoint. It matters from a moral standpoint. And, again, we're human beings. We're here, and we're not going anywhere. So if you want your systems to be healthier, if you would like to retain really great talent and tap into the resilience and just the greatness that exists in Black and Brown communities, like, support us, care about us. And in doing so, everybody benefits. So, that's my thought on it. I think that could be a whole other conversation too.
Next time.
Yeah, next time. Thank you so much.
Thank you, Marissa. We really appreciate you coming in. I feel like we are good to go.
Great. Yeah.
That was great.
That
was great. Great job. You're
Thanks.
a natural at this.
So are you.